Hi, my name is Stacy Pelekhaty, and I'm the Senior Clinical Dietitian at the R. Adams Cali Shock Trauma Center at the University of Maryland Medical Center at Baltimore, Maryland. Today's course, Nutrition Basics for ECMO, is just one of a series of subjects brought to you by Channel 1 on-demand nutrition education. Today, we're looking at nutrition basics for extracorporeal membrane oxygenation in adults. My objectives for this presentation are to provide a brief overview of ECMO and how it works, to review the current literature on energy, protein, and fluid targets for adults on ECMO, and to discuss micronutrient considerations for patients on these therapies. The way ECMO works is two large cannula are placed into the patient, and the positions of those cannula are determined by the type of support the patient needs, whether that's respiratory, cardiovascular, or both. The oxygenated blood is removed from the outflow cannula. That's passed through a mechanical pump. Then, using the centrifugal force from the mechanical pump, the blood passes through an artificial capillary bed known as an oxygenator. That is the site of oxygen and decarboxylation. After the blood is oxygenated, it's returned to the patient through the inflow cannula. There are some considerations for nutrition assessment in these patients. Weight assessments and nutrition-focused physical exam can be complicated both by edema, particularly in patients who have undergone prone positioning, and volume overload. Additionally, these are patients that are a unique subset of critical care, and extrapolating energy, protein, and micronutrient considerations from general critical care into this population can result in suboptimal decisions. For indirect calorimetry, which we all know is the gold standard assessment for energy needs, the challenge with ECMO patients is that up to 100% of gas exchange is occurring at the oxygenator. And indirect calorimetry methods that don't capture that gas exchange will not provide results that are valuable or reflective of the patient's energy needs. Due to these technical limitations, predictive equations have not been able to be thoroughly validated in this population. There are also a range of recommended predictive equations depending on which body or oversight you're looking at. You can see anything from 20 to 30 kcals per kilo, as well as the Penn State equations. One thing that I will note about the Penn State equations, if you are going to apply them in this population, is that minute ventilation from the ventilator is not an accurate reflector of oxygen demand in the population. So I do urge caution when you're attempting to use those equations. Regarding cals per kilo, with 25 to 30 kcals per kilo, looking at patients on VV ECMO, there have been two retrospective studies. And when patients receive a higher proportion of that energy delivery, it's associated with an increased duration of ECMO without mortality benefit. This is likely due to patients being very sensitive to overfeeding, and 25 to 30 calories per kilo likely being too high in this patient population. Patients on VA ECMO, you didn't see the same increase in duration of ECMO support. However, it still may be too high in the population. More research is needed. Pending additional validation literature, 20 to 25 kcals per kilo is a reasonable starting target for these patients. And in patients with very high BMIs, you may want to consider using ideal body weight to avoid that effective overfeeding. When it comes to protein needs, nitrogen-bound studies have demonstrated that patients on ECMO have high protein needs. However, these will vary widely among individuals and over the course of ECMO. Two retrospective studies looked at protein delivery in patients on ECMO, and when at least 1 gram of protein per kilo per day is delivered, increasing protein delivery is associated with reduced mortality. But we've all heard that protein can be dangerous in patients that are critically ill, especially very sick patients that are critically ill. And one can argue that patients on ECMO are the sickest patients in the ICU. So how does that all make sense together? Patients on ECMO have a high rate of concomitant use of renal replacement therapy, and the post-hoc analysis of the EFFORT protein trial demonstrated that when patients receive renal replacement therapy, the negative impacts of high protein loads are not observed. Additionally, the nitrogen balance studies that I just referenced are often done after the first several days, after the first week of initiation on ECMO, and that likely contributes to patients not having as negative an impact because you're slowly ramping up your nutrition support targets to a goal after the first week when patients are most sensitive to high nutrition targets. However, individualization really is key because, as I mentioned, the needs can vary widely patient to patient. Nitrogen balance is a really great tool to be able to individualize your nutrition support to your patient, as well as to assess whether or not the nutrition support you're providing is meeting the individual patient's needs. I do recommend with patients on ECMO liberalizing your definition of equilibrium to -4 to +4 grams per kilo per day when doing nitrogen balance, because it can be very challenging to achieve really tight nitrogen equilibrium in this population. When we think about fluid needs in ECMO patients, it's a bit of a double-edged sword. A certain amount of fluid resuscitation is needed to support adequate blood flow through the ECMO circuit and prevent things like chugging. However, volume overload is associated with negative clinical outcomes. So when it comes to our nutrition interventions, we want to make sure that we're not contributing to negative impacts on either side. We want to make sure that we're not providing excess volume from our nutrition support so that we're not contributing to volume overload. However, restricting your nutrition regimen, which can contribute to development of malnutrition, as well as require the patient receiving additional fluids to support their volume status, is not going to benefit them. So our goal there is to provide the minimum needed volume to meet their nutrition targets. And we do this ideally through early enteral nutrition. Post-pyloric access can help to support patients receiving their nutrition targets, but it is not required, particularly if it can be challenging at your institution to achieve those post-pyloric tubes early on in critical care. When you're thinking about your tube feed formula, selecting something that has high protein content can help to support meeting these high protein, low calorie targets. And in patients who are unable to achieve their enteral nutrition targets, especially by ICU day 5, parenteral nutrition should be considered. Lipid emulsions can be infused in patients on ECMO. They're not associated with oxygenator occlusion. And we shouldn't be avoiding parenteral nutrition in this population to prevent infectious or hepatic complications. Some things you can do with parenteral nutrition to help to support avoiding these complications are preventing over and underfeeding. Using trophic enteral nutrition can help support the gut-associated and mucosal-associated lymphoid tissue, as well as gallbladder contractions. Cycling can also help to support the liver. However, it's not recommended until patients are stable and not generally used early on in critical care. When we think about micronutrients in this population, the ECMO circuit does not appear to sequester nutrients. However, if a hemoconcentrator is placed in line, that will draw serum off of the blood. This will lead to loss of protein, protein-bound micronutrients, and any nutrients that are circulating in the serum. In addition, up to 50% of patients will be supported with continuous renal replacement therapy, which is associated with increased losses in water-soluble vitamins and minerals, and increased rates of deficiency in certain minerals that are not lost in the effluent. Zinc is a really good example of that. There are high rates of zinc deficiency on CRRT, even though it is not lost in the effluent. After 2 to 3 weeks of these therapies, increased rates of carnitine deficiency are reported in the literature, and vitamin D deficiency is very common in patients that require ECMO support. Summarizing all of this, for the first 2 weeks of critical care on ECMO support, about 20 kcal per kilo is a reasonable target. And in patients with high BMIs, using ideal body weight can help to support the avoidance of overfeeding. After 2 weeks is when you, if clinically appropriate, you can begin to advance your nutrition as clinically indicated. Patients have high protein needs, but they can vary widely among patients. And also within the same patient over time, nitrogen balance is an excellent tool that can help to support that individualization of care. And in patients, all critically ill patients and ECMO patients in particular, we do want to gradually increase our nutrition support. We don't necessarily want to hit them with 100% of their needs right out of the gate. Fluid management is truly a critical care intervention, not necessarily a nutrition intervention in these patients. And micronutrients are of concern because there are high risks for multiple deficiencies, and these risks are compounded when there's concomitant use of CRT or hemoconcentration. I thank you very much for your time and attention to this presentation, and I hope it helps you take care of patients on ECMO.